again this is honeycombing. With ground glass haze and the thickened septa. So reticular densities, whenever we clinically suspect idiopathic pulmonary fibrosis, collagen vascular disease, asbestosis, chronic pneumonitis, and sarcoidosis. So the site of these reticular densities will let us know that actually which disease we are dealing with. So here again there are ground glass opacities and septal thickness. Different stages of the same disease. So when we talk of the nodules present in the Hrct pattern, then certain diseases come to our mind straight away. The sarcoidosis, silicosis, Kohlwerker's pneumoconiosis, hypersensitive pneumonitis, tuberculosis, and metastatic disease. So nodules is not a heritage of metastatic disease. The infectious and the inflammatory disease both can lead to such problem. And nodules can be perilymphatic, random distributed, and centrilobular. The perilymphatic nodules can be due to sarcoidosis, silicosis, and lymphangitic CA. So what type of nodules these are? It includes the airspace lesion with fuzzy borders. You can see here that the nodules include the airspace with fuzzy borders, interstitial nodules with sharp, unsharp, or satellite margins. These are the unsharp margins. And the sharp interstitial nodules, they are usually seen with Langerhans cell histiocytosis, silicosis, metastatic disease, miliary tuberculosis, and disseminated fungal diseases. And the unsharp are found in sarcoidosis and hypersensitivity pneumonitis. And you can see these are unsharp type of nodules. So we can suspect that either this is a case of sarcoidosis or a case of subacute hypersensitivity pneumonitis. Now if we find nodules, then we have to see that whether they are present in a perilymphatic region or if they are randomly distributed, are they centrilobular or the airspace nodules, because they all have the different etiologies. So the perilymphatic nodules are subpleural in location and also found along interlobular septa, interlobular fissures, and along bronchovascular bundles. These अगर बीच में भी disconnect हो जाए तो दोबारा connect कर लीजिएगा, including me. These nodules tend to be non-uniform and patchy in distribution, have a tendency to cluster. The perivascular nodules have a similar subpleural distribution but show a uniform and diffuse distribution. The centrilobular nodules, they are subpleural, and the lung underlying the interlobular fissure, they are found to 5 to 10 millimeter away from the pleural surface. And the airspace nodules are centrilobular and can also form the tree in bud pattern, but they are slightly larger than the typical centrilobular. And we all know that such nodules can be seen in infective and inflammatory disease also. अभी हमारे एक पीजी ने इस पे कमेंट किया था ट्री इन बड अपीयरेंस पे, तो वो एयर स्पेस नोड्यूल्स होते हैं जो कि ट्री इन बड अपीयरेंस बनाते हैं, तो जो कि ट्यूबरकुलोसिस का है, ये जैसे इसमें नजर आ रहे हैं ये. Okay, so again nodules. So what type of these? Are they subpleural nodules? Anyone? They look to be centrilobular nodules because they are sparing the subpleural region and they are 5 to 10 millimeter and they are away from the pleural surface. So they are centrilobular nodules, and this is a feature of hypersensitive pneumonia, sarcoidosis, Langerhans cell histiocytosis, and cellular bronchiolitis. This is metastasis. You can see that these are nodules, they are representing the metastasis. So what type of nodules are metastases?
Random.
They are random, hematogenous or perivascular nodules. Random or perivascular nodules have a similar subpleural distribution but show a uniform and diffuse distribution. They do not cluster. They are the result of hematogenous dissemination and are characteristically found in miliary tuberculosis, in fungal diseases, and in metastatic spread and in septic embolization. So these are the classical picture of random hematogenous perivascular nodules. These are subpleural nodules, and as we know that subpleural nodule is a feature of either perilymphatic nodule, so which may be due to lymphangitic carcinomatosis or silicosis. Again, perilymphatic nodules, subpleural, and with thickened interlobular septa or interlobular fissures, and this is also a feature of silicosis, sarcoidosis, and most likely lymphangitis carcinomatosis. These one. So they are all representing different. Here you can see this is metastatic adenocarcinoma, which again shows that these are random, homogeneous, and perivascular nodules. Now, who will answer this? What is this?
Random nodule.
Very good. These are random nodules. This is a case of bronchoalveolar carcinoma. You will remember it and you will never forget it. This is a case of bronchoalveolar carcinoma. So these are typical tree in bud appearance. So as we have just discussed, the tree in bud appearance nodules are centrilobular nodules or random nodules or airspace nodules. Anyone? In tree in bud appearance, what type of nodules are random, centrilobular or airspace? Look at
airspace.
They are slightly larger and exactly. Who is this? Great, Amashiraz. These are airspace nodules. They are also form the tree in bud pattern, and they are slightly larger than the typical centrilobular nodules, and they are seen in tuberculosis, infectious bronchiolitis, and diffuse bronchiolitis. Very good. So this is tree in bud appearance. So this is again a feature of perilymphatic and perilymphatic nodule. So perilymphatic nodule are found in silicosis, lymphangitis carcinomatosis, and in certain cases of sarcoidosis. it is usually associated with interlobular thickening. As you can see here that these are the nodules and there are interlobular thickenings are there. So this is a feature of metastatic spread or miliary. We have already discussed that. These are the few CT scans showing ground glass haze. That this is without disturbing the lung parenchyma, without interstitial thickening. So can anyone tell if in ground glass haze there is interstitial thickening, then what we name that ground glass haze?
Tram track.
Then we call it crazy pavy appearance. So here there are few areas of crazy pavy appearance. There are few areas of crazy pavy appearance. Rest of other are ground glass haze. So these are consolidation and air space filling. This is consolidation and air space filling. So when we use this word, it means that in contrast to ground glass attenuation, there is vascular structure and there is accompanied air bronchocrown. So in what conditions it is seen? It is seen in pneumonias, in pulmonary edemas, in diffuse alveolar damage and in pulmonary hemorrhages, because the underlying process is replacement of alveolar gas by pus or fluid or blood or loss of surfactants. So they all will give rise to the same picture, and clinically we will have to figure out that what patient is suffering from. This is interstitial lung disease. Again, you see that there is peripheral ground glass haze, and in the center there is septal thickening. So there are few areas of crazy pavy appearance and few areas of bronchiectasis, and rest there are basal ground glass appearance. So this is a case of non-specific interstitial pneumonitis, NSIP. Again, you see that there is ground glass haze. This is a very interesting CT. I want you to pay attention, because this is, you say that this is ground glass plus. You can see that there is ground glass haze, but in between ground glass haze as compared to the previous one, you see that there is ground glass haze here as well, but it is in between there is no septal thickening. But if you look at if you look at can you hear me? If you look at this X-ray CT scan, you can see that in between ground glass haze there is septal thickening. So this is crazy pavy appearance, typical crazy pavy appearance. And this is a case of alveolar proteinosis. So all this mosaic perforation. Now what is mosaic attenuation? This is a CT scan which is showing mosaic attenuation. This is the redistribution of blood flow towards normal parts of the lungs, and it may lead to increased attenuation of uninvolved parenchyma. So this pattern of variable regional attenuation of lung parenchyma due to regional difference in perfusion is known as mosaic perfusion or mosaic attenuation. So, what clinical conditions lead to this disease? The diffuse infiltrative lung disease leads to such problems. Consolidation we see daily, and we know that the hallmark of consolidation is here bronchogram, and this is a case of chronic eosinophilic pneumonia with peripheral ground glass opacity, thickened interstitial septas, and few areas of interstitial thickening. This is bronchiolitis obliterans with organizing pneumonia or cough, and you can see that there are basal ground glass haze with areas of septal thickening, some centrilobular nodules and some scattered nodules, and this is a classical Hrct for bronchiolitis obliterans with basal predilection of the ground glass haze and other abnormalities. Now, if we talk of cystic airspace disease, then clinically we come across lymphangitis leiomyomatosis, Langerhans cells, and end-stage lung. So, this type of CT scan, if you come across, then there it clearly shows that there are cysts. Cysts are there as focal region of low attenuation with perceptible well delineated walls, and emphysematous spaces and bulli usually have an imperceptible wall and occasionally central vessels. You can see a bright dot in between these cysts representing the vessel. The bronchiectasis cysts display the signet ring due to accompanying artery in their wall, and cyst can be seen in end-stage lung disease with honeycombing in interstitial pulmonary fibrosis, collagen vascular disease, Langerhans cell histiocytosis, lymphangioliomyomatosis, lymphocytic interstitial pneumonia with follicular bronchiolitis, and in discoamative interstitial lung disease. All you can see scattered cysts, bilateral with thickened septas, few containing signet rings and other having discrete walls. So this is cystic lung disease with all these differentials which we have just discussed. This is LAM, lymphangioliomyomatosis. Again, cysts, bronchiectasis, thickened septas, few areas of traction bronchiectasis. Subpleural haze, cystic disease, and subpleural haze showing lymphangioliomyomatosis. And again, Hrct showing cystic disease with a few areas of signet ring appearance. You can see the central vessels in few of them and thickened septas. So this was an overview of the Hrct, and hopefully you must have recalled all your clinical background to assess the disease. So before we say goodbye to each other, I let you know that distribution is very important of all these things. So if the upper parts of the lungs are typically involved, then you may say that this is granulomatous disease. Langerhans cell histiocytosis, pneumoconiosis seems to be involved. Then it is inflammatory bowel disease. It is idiopathic pulmonary fibrosis, collagen vascular disease, NSIP, asbestosis, benign age-related or smoking-related problems. frequently affected than idiopathic pulmonary fibrosis. Drug reactions, eosinophilic lung disease, organizing pneumonias, desquamative interstitial pneumonias, rare cases of pseudoalveolar sarcoid. And the predisposition for involvement of the posterior superior region of the lung is found in tuberculosis, fungal diseases and silicosis. And whenever you see a diffuse involvement of the lung, then lymphangioliomyomatosis and inflative lung disease, they are the most commonly labeled clinical diseases. So not only the anatomical landmarks disturbance tells us about the disease, but also the zones and the areas let us know that what clinical disease could it be. Thank you very much. So
Thank you.
the forum is open.
Thank you, sir.
Thank you, sir.
Okay. So here we